Hello and welcome to the Multiple Sclerosis Association of America's live webinar, What You Need to Know About COVID-19 and MS, Program 8. I am Peter Demiri, Vice President of Programs and Services for MSAA and your host for tonight's program. On behalf of MSAA and our presenters, we greatly appreciate the opportunity to keep you updated on this very important topic, and please know that we hope you and your family are staying safe and healthy in these challenging times. MSAA is extremely honored to once again welcome back our two MS expert advisors who will update us about the coronavirus pandemic and its impact on MS and answer your questions during our expanded Q&A session. At this time, I would like to introduce our guest presenters, Dr. Barry Hendon and Dr. Carrie Hirsch. Dr. Barry Hendon is a practicing neurologist, MSAA's Chief Medical Officer, and Director of the MS Center of Arizona. He is also the director of the Multiple Sclerosis Clinic at Banner University Medical Center and clinical professor of neurology at the University of Arizona Medical School. Dr. Carrie Hirsch is a practicing neurologist and the chair of MSAA's Healthcare Advisory Council. She is an assistant professor of neurology for the Cleveland Clinic Lou Ravoux Center for Brain Health in Las Vegas, Nevada. Thank you both again for being here tonight and providing us with such timely and important information about COVID-19 and the new FDA-approved vaccine.
Peter, Dr. Hersh and I are delighted to join you once again for what we believe is a very important topic and a very important ability to talk with the MS community throughout the country.
Great. Thank you, Dr. Hendon. Before we begin, I want to take this opportunity to thank our supporters, Bristol Myers Squibb, EMD Serono, Genentech, Novartis, and Sanofi Genzyme for making this webinar series possible. As you may know, MSAA is a national nonprofit organization dedicated to improving lives today for the MS community. Listed here are just some of the many free programs available to the MS community, including our COVID-19 and MS Pathfinder tool, which provides ongoing updates and resources on the coronavirus pandemic. Also, please know MSAA has expanded our helpline hours to 8 p.m. Eastern between Mondays and Thursdays. To learn more, please visit mymsaa.org or give us a call at 1-800-532-7667. And lastly, please know tonight's webinar will be archived on our website within a few days. For the Q&A session, please type your questions into the chat box on the screen and we'll address them at the end of the presentation. Also, if you're having any technical issues, please type those concerns into the chat box as well. So at this time, I would like to turn the program over to Dr. Barry Hendon, who will kick off tonight's presentation.
Thank you again, Peter. You'll see the first slide is a summary of key points to remember. And what is notable about this first slide is that much of this we began saying early in 2020 when we learned about the virus, so that some of the things we'll be talking about are unchanged. That is how we should, as a community, try to reduce the risk of COVID-19. Some, of course, is rapidly changing, and that's the reason that we've had updates. Dr. Hersh and I have joined each other and you all with updates because although on one hand we're learning about a new virus, that new virus is mutating rapidly. Therefore, our need to keep up to date is really front and center. We're very aware of it. So what are the things that we've been saying all along? That COVID-19, the coronavirus, is a highly contagious and potentially serious inflammatory disorder that targets the respiratory system, but a lot of other systems are involved, and that means, and that includes the central nervous system and peripheral nervous system. So patients who have gotten COVID-19 have also suffered some other complications. They've included strokes and seizures and loss of sense of smell and taste. So it's a respiratory focus, but involves multiple systems. The thing that has not changed at all is how do we as a community reduce the risk of infection. It is wear a mask, wash your hands, practice social distancing, and maintain wellness and good health. And that means this virus is particularly difficult when there are comorbidities and when those comorbidities are poorly controlled. So uncontrolled diabetes, cigarette smoking, obesity, all those things. It just reminds us of our need not just to wear a mask, wash your hands, practice social distancing, but really to focus on our own good health habits, our own wellness habits. Remember, this is the best time to stop smoking if you do, to get your weight under control, to begin a regular exercise program, to maintain emotional wellness, et cetera, et cetera. So we are aware that having MS in and of itself does not create a greater risk for COVID-19. The risk factors relate to comorbidities and age. So if there's a high level of disability in MS or other conditions, that creates risk. Age in and of itself creates risk. 60-year-olds are at greater risk than 50-year-olds, 70-year-olds greater risk than 60-year-olds, 80 than 70, et cetera, et cetera. And the other comorbidities that we always watch are chronic renal disease, chronic heart disease, lung disease, diabetes, cancer. Don't forget those that are controllable, and that means things like obesity and smoking. We've said all along that disease-modifying therapies shouldn't be stopped or changed unless it's clinically appropriate after discussion with your MS clinician. Partly, it reminds us that we should be collaboratively thinking about this, clinician and person with MS. But we also know that for some of the disease-modifying therapies, stopping the medication actually runs the risk of a rebound or increase in inflammatory reaction or relapses. So currently, we have 2 FDA-approved and available vaccines for COVID-19, one from Pfizer, one from Moderna. As you probably know, we have others on the way, but this is the current state of affairs. So all these slides, except the last, I've been saying in each of the previous sessions. The very hopeful new addition is that we currently have 2 FDA-approved and available vaccines for COVID-19. I'll now turn to some questions that we have that have been written in for Dr. Hirsch and for me, and we'll begin to answer those and then make ourselves available for those questions which you may put into the chat box. So, Dr. Hirsch, the first question is for you.
Sure. Thank you so much, Dr. Hendon. And first, I would like to thank the MSAA again for hosting such a timely and informative program for all of our listeners. I would also like to thank for your time and attention this evening. I'm hoping that this will be a pragmatic and useful array of information that will help with decision making. And of course, Dr. Hendon and I look forward to answering your questions at the end of the program. So please feel free to continue typing in your questions for us. I see some are already starting to come in. So the first question, is it safe for a person with MS to take one of the available COVID-19 vaccines? And overall, the simple answer is yes. We do feel in the MS community that it is safe for someone who is living with MS to take one of the 2 available vaccines, which are mRNA vaccines, the Pfizer vaccine and the Moderna vaccine. Neither of the vaccines contain live virus, and they will not cause COVID-19 disease. And the vaccines are not likely to trigger an MS relapse or to worsen chronic MS symptoms. And we feel that the risk of getting COVID-19 far outweighs any risk of having an MS relapse from the vaccine. But it is important to remember that any vaccine can cause side effects, and this is a natural reaction to the immune response starting to develop a reaction to the vaccination itself and building an immune response, which is what we want. Some of those side effects can include local injection site reactions and arm pain. It can include mild headaches, mild fevers, chills, and every now and then it can also cause some side effects that include flu-like symptoms in addition to that. Any kind of fever can make MS symptoms feel worse temporarily, but we do anticipate that any of those pre-existing MS symptoms that may temporarily worsen during one of these systemic reactions to the vaccine will go away once those vaccine response symptoms resolve. And even if you do have side effects, it is important to get the second dose of the vaccine if it is indicated to get a second vaccine, which it is with the two existing available vaccines to date, in order for it to be considered fully effective. So Dr. Hendon, the next question is for you.
Sure, and I think, Dr. Hirsch, I think you've already begun to answer some of the question that would be part of this. How does the vaccine affect my MS? And so I would agree entirely with what you said, and probably just reiterate. There were very few MS patients in the research trials, and so it's hard for us to state exactly with certainty how will the vaccine affect my MS. But the information we have so far is that exactly as Dr. Hersh said it, that is that we do not expect the vaccine to worsen a person's MS or to cause an exacerbation or relapse in MS. And so we do not specifically believe, based on the limited available evidence, that it will affect your MS in any permanent way. On the other hand, number one, as Dr. Hersh said, if you have a fever associated with the injection, first or second, the fever will do what is often called a pseudo-exacerbation. That is, while your temperature is up, your MS symptoms may heighten. When your temperature goes back down to normal, those will go away. The second thing is that to the extent that the vaccination produces aches and pains and the flu-like feelings, it may be just added on to your MS symptoms, just as a second layer would be added on if you had the flu. I will tell you, I told Dr. Hersh that she and I are in an unusual way vaccine experts, because Dr. Hersh has had her first vaccine, and I've had my first and second vaccination. For a lot of people, the first vaccination is pretty simple, although some will have aches and maybe a fever. The second one can be a little more difficult, but again, only in a short-term basis. So can it make you feel a little fluish or off in the first 24 hours? The first vaccine, yes. The second vaccine, a little more likely, but it will not affect the long-term course of your MS. Dr. Hersh, the next question, I think, is yours.
Okay, thank you. So the next question, will different Msdnts affect the vaccine's effectiveness? So this is a very common question that is coming to us in the clinic, and we felt that it would be highly important to address that during tonight's presentation. So if you have been listening to our webinars throughout the course of the middle of 2020 up until recently, Dr. Hendon and I have both been communicating that continuing the disease-modifying therapy for long-term MS outcomes is highly encouraged, and to not stop any disease-modifying therapies unless this is a decision that is made between you and the healthcare provider because of individualized reasons. The reason for this is because stopping a disease-modifying therapy can, and if it's done abruptly, can cause severe increases in disability or a severe relapse or new MRI lesions, especially if they are certain disease-modifying therapies that if you stop them abruptly, one can be more prone to rebound disease just because of the way the medicine works. And some of those medicines include natalizumab and some of the S1P modulators such as fingolimod, siponimod, and ozanimod. But to answer the question at hand, from what we can gather from previous studies of other vaccines and certain disease-modifying therapies, getting the COVID-19 vaccine while on any disease-modifying therapy is considered safe. However, some DMTs may make the vaccine less effective, but it will still provide some level of protection. And how much that response will be attenuated or lowered, and whether or not this will yield a difference in clinical response, we just don't know at this time. And as Dr. Hendon and I have mentioned before, this is a very quickly and evolving environment with COVID-19 and now vaccination responses. And not only do we anticipate, we expect that there will be phase 4 clinical trial data, there will be observational studies, and there'll be registry studies looking into the biological and clinical effectiveness of mounting an appropriate COVID-19 vaccine response on certain disease-modifying therapies. And some of these therapies that we think there may be an impact on the effectiveness include medications like the anti-CD20 therapies, or what we call the B-cell depleting agents, such as ocrelizumab or ofatumumab, other medications that are global immunosuppressive therapies that we do anticipate will have an impact on the B-cell population, which is important for creating antibodies. Those include cladribine and alemtuzumab. And of course, rituximab is another anti-CD20 B-cell depleting therapy. So right now, there may need to be some coordination in the timing of the vaccine with the timing of the disease-modifying therapy dose. But right now, we do not have any formal consensus guidelines that are spearheading global decision-making protocols amongst MS clinicians. So this may be very well patient-specific and provider-specific, and this is where we do encourage to have a conversation with your MS provider when determining when it would be the best time to get one of the available COVID-19 vaccines when it is made available for you. But we do feel that with any of the disease-modifying therapies, there will be effectiveness. It just depends on whether or not an individual is on an immunosuppressive therapy that impacts the B cells that lower antibody response and thereby the vaccination response. How much of that may be something we need to look into. But other disease-modifying therapies like letermovir acetate, any of the interferon betas, carfilzomib, any of the fumarates or the S1P modulators where there's no evidence of significant lymphocytopenia. We do not believe that there's going to be a necessity to make any changes in the timing of disease-modifying therapies and coordinating the vaccine. So if you do have any specific questions when it comes to your particular scenario, I certainly encourage to follow up with your MS provider for specific questions. and Dr. Hendon.
Sure. This one I can answer pretty quickly, and it says, is one vaccine better to take than the other? So currently we have two vaccines. They both have high levels of effectiveness and efficacy, and there is no clear winner or loser between the two of them. I certainly was, I received one of those two. I received the Pfizer, and on the other hand, would have been equally happy to have received the Moderna. We have other vaccines coming around the corner. They have slightly different mechanisms or slightly different vehicles. One of them will be a 2-injection formula. One will be a 1-injection formula. There's some discussion as to whether or not we may need another additional booster at some point in time because the virus keeps mutating, and we may want to have a booster that deals with the later mutations. So the answers are current answers, and they may change the next time Dr. Hirsch and I are on the phone, which I think may be in early April, the next time that we're on the webinar with you. The thing that I would like to say to make clear, the MSAA, in conjunction with the National MS Society and the Consortium of MS Centers, has put out a statement about the vaccines, and that is, we recommend that people with MS be vaccinated. And there should, of course, be a discussion with your clinician, your healthcare provider, where some exceptions might be acknowledged, and further discussions may be necessary. But the joint statement is that we do believe people should be vaccinated. Which vaccine you get is which one is available. And as I was delighted to get the one that was available for me first, I would say the same for you, and that is take the one that becomes available. The sooner we are vaccinated, the healthier the general community. Dr. Hersh.
Okay, thank you. So the next question, should I first take my vaccine or my upcoming infusion? So this is actually a nice segue into the question that I just answered a couple of minutes ago. And, you know, again, this is a very common question that comes up in clinical practice, and certainly one that deserves, you know, us to be very aware of. The simple answer to this question is it depends on when in the upcoming infusion, where in the infusion course you are, and whether or not the vaccine is readily available. And of course, it also depends on what kind of infusion this is, whether or not this is an infusion with natalizumab, where we're not necessarily making any recommendations for specific timing of getting the vaccine and getting the infusion, simply because it doesn't impact B cell levels, or whether or not this is one of the anti-CD20 B cell depleting agents. So as Dr. Hendon had mentioned, we are taking a stand in that we do feel that folks with MS should get vaccinated. And if one is being offered the opportunity to go ahead and get vaccinated, and they are within a specific time frame of being able to get the vaccine with a good window before their next infusion is due, then I would say yes, it would certainly make sense to go ahead and get vaccinated. Now, with that being said, we, again, do not have any formal guidelines when it comes to timing of getting vaccinations when it comes to certain disease-modifying therapies that we had just reviewed. The anti-CD20 therapies are some of the most commonly approached medications in terms of whether or not there needs to be a specific timing. And some healthcare professionals are of the impression that there does need to be specific timing, and then others do not feel so. So, I certainly have my own theories and anticipations based on how B-cell depleting therapies work. But I certainly would encourage anyone to have that conversation with their MS provider in terms of whether or not it is an appropriate time frame to get the vaccine before their upcoming infusion, whether it is a B-cell depleting therapy or another disease-modifying therapy, because that particular provider may or may not have particular knowledge in terms of the person's immune system, and then, of course, any other comorbidities that may increase their desire for the individual to get vaccinated versus getting the infusion. So it really just depends on the individual. In my clinical practice, I will just go ahead and throw this out there that I feel that it would probably be a good time frame to get one of the vaccines at least 12 weeks after having one of the anti-CD20 therapies infused, and that would include rituximab or ocrelizumab. And then to have the second vaccine injection no sooner than 4 weeks before the next infusion is due, to make sure that the person is able to mount an appropriate immune response. But like I said, there are no formal guidelines, and this is based on best clinical judgment.
So I'm going to summarize a little, and this is a little redundant, but before I answer the next question, what you've heard so far, simplified, might be the following. Should you be, if you have MS, should you be vaccinated? The answer is, after discussion with your clinician, we are really advocating for vaccination for the general community and equally for the MS community. And to the question, might it depend what medication you're taking as to whether or not you should be vaccinated? The answer is no. We are not. We are recommending that people with MS be vaccinated, with rare exceptions, and that although obviously there should be a discussion with your clinician, that we are really recommending for vaccination. If you've got MS, if you don't have MS, if you're taking a disease-modifying therapy or not, and that's a message I want to leave you with. Despite the complexities, there is that simple message. So the next question, can a person with MS who previously tested positive for COVID-19 still get the vaccine? The answer is not only can they, but we are recommending that people who have tested positive for COVID-19 be vaccinated. There is a question as to when that should be done. We don't have clear-cut answers, but right now the recommendations generally are, without a lot of evidence, that it might be optimal to wait a few months after you've tested positive for COVID-19 to get your vaccination. The question that you all might ask is, why would I be vaccinated if I have already developed immunity based on having gotten COVID-19? The answer is you will have developed some immunity just from having gotten COVID-19, but we're not sure the degree of that immunity, which is to say how much immunity or how long lasting. So the vaccination would really be an extra layer of protection. And I keep emphasizing the protection is not only for you, but for your community. So we're doing two things. We're protecting ourselves and we're protecting others. Dr. Hersh.
So the next question is, should I get the flu shot? And if so, do I need to wait between getting the flu and COVID-19 vaccines? So the simple answer is yes. It is recommended that folks who are living with MS should get the seasonal flu vaccine. These are inactivated vaccines. They will not cause an influenza infection, nor will it cause MS exacerbations. It is considered a little bit later in the flu season, but I do encourage my patients still, if they have not gotten a seasonal flu vaccine, to go ahead and get that done. The second question is whether or not there needs to be a specific amount of time in between vaccines. And it's not just the seasonal flu vaccine. This is any vaccine, such as a shingles vaccine or a pneumonia vaccine. But the general recommendations is to wait at least 2 weeks in between immunizations, and this comes directly from the CDC.
So the next question is it safe for me to access medical care, doctor visits, MRI, blood work, infusion, etc.? It should not surprise you that Dr. Hirsch and I talk about each of these questions before we ever address them, to find out how much we agree and how much we disagree. This one, I remember Dr. Hirsch's comment, which was, please get medical care. Treat your stroke, treat your heart, treat your. So we both agree that one of the things that's happened in America, in addition to the problems that have occurred due to COVID-19, infection itself, has been an increase in other medical problems which have been unattended. The strokes, the heart attacks, etc., for which people have been unwilling to go to emergency rooms, the medical care for which they have been unwilling to seek follow-up, etc., etc. So the first thing is really nothing about COVID-19 makes you immune from the rest of your medical health. It's important to pay attention to all the rest of your general medical health, and that means heart, lung, liver, kidney, et cetera, et cetera, et cetera. The next question is, what about doctor's visits? And I'm going to go sort of one by one. Doctor's visits. Interestingly, for many of you, and certainly in my own practice, there is a hybrid. So much of the care that I'm providing by telemedicine to reduce risk of coming into a medical facility. I still see patients face-to-face. I still see patients on telemedicine. I find that this hybrid is one that will probably continue into the future. I'm sure Dr. Hersh, as I do, have patients who live 100 or 200 miles away, or for whom getting out of the house is both a general difficulty and a risk. And so I've been very, very happy to be able to provide telemedicine visits. But a good medical facility will keep you safe as you visit, and that means wear the mask, maintain social distancing, maintain good health habits when you make that visit, and expect your healthcare facility to do the exact same thing. What about MRIs? I get MRIs as appropriate. I do admit I asked myself before the MRI, I think a year ago or 2 years ago, I might have more reflexively ordered the MRI. I now still order the MRI when needed, but I find myself being a little more questioning of myself, and that is this particular MRI really necessary? Blood work, the kind of blood work we get to make sure that the medicines we're using are not creating increased risk remain necessary. I think of JC virus testing when people are on Tysabri, or liver testing when they're on Aubagio, or CBCs when they're on fumarates, or B cell or immunoglobulins when they're on B cell depleting therapies. Those things are how we keep you safe. And so to not do them really may change the risk of your medication. Don't avoid doing so. Infusion's the same. And so I have been keeping people on their regular infusions, their regular blood work, their regular MRI, and their regular visits, even though I will ask myself on each occasion, is this in fact really necessary? The things that you may wonder about are, how do you get to the doctor visit? Most of the people in my practice get to my office, if they do have to come, by car, but there's a second layer of risk if they needed to take public transportation, et cetera. Remember the current advantage in telemedicine when those risks are too high. So, simple answer, yes, it's safe to access medical care. It's also unsafe not to access medical care. That means neurologic care and general care, but keep thinking about what's necessary and what isn't, and hope that your clinician will do the same. Dr. Hirsch?
All right, and I will go ahead and I will close out at least the frequently asked questions, and then we'll make sure that we get to all of your questions, because I see that there are many coming in, and we certainly want to address as many as we can. So to close this out, I wanted to try to give this more of a positive spin, because this has been a highly challenging time for all of us, whether or not one is living with MS. At times it can feel isolating, and it certainly can be discouraging and disheartening when you're unable to spend time with your loved ones, especially as we just finished up with the holiday season. So I do want to make sure, and I know that Dr. Hendon is a huge proponent of this, that we certainly continue to encourage the importance of health and living. And, that certainly includes physical health, and it also includes mental and psychological health as well. So we continue to stress the importance of eating healthfully. That does include an anti-inflammatory diet, 3 square meals a day. Mediterranean-style options are nice for an anti-inflammatory nutritional regimen that certainly has high benefits for general health, but also for MS health as well. Routine physical activity and exercise is also very important. Not only is it good for general health and MS health, but it also is a releaser of endorphins, which are your feel-good hormones. So making sure that you are moving about and having some form of physical activity throughout the week should certainly be stressed. And speaking of stress, this has certainly been a very stressful time. And so I continue to encourage people to reach out to your loved ones, your family, your friends, even if it's a telephone call or, a face-to-face through virtual means, just a simple connection for a few minutes a day, can certainly help feel that connectedness with your loved ones, and it can certainly lower the feeling of isolation that I know a lot of us have felt over the past year. And of course, a lot of this can be even more challenged by the fact that we are in the middle of winter and it's very cold out, and learning how to be creative about how we can remain connected and how we can be physically active, without going to a gym where we may feel that the risks of COVID-19 exposure, may be higher than the potential benefits. So I would certainly encourage you to continue to live healthfully, live your best lives for general health and for MS health. And if you do feel that you are continuing to struggle despite lifestyle strategies, please reach out to your healthcare provider. There are mental health specialists who are available. There are certainly programs that are available through the MSAA, the National MS Society, and certainly do not hesitate to reach out if you feel you are continuing to struggle and need some extra care. So with that, Peter, I think that we can go ahead and move on to the frequently asked questions. I think we only have 20 minutes left.
So Peter, I might jump in if I might. Although this is I'm going to let you take over, Dr. Hersh requested, but I saw that there were a couple questions that related to age. And since I may be a specialist also in age in MS. I thought I'd try to answer that a little bit. One was the question of age and risk of COVID-19. And the answer for that one's very clear, and that is, although COVID-19 has risk at any age, there are children who have died from COVID-19 and elderly people who have survived. It's still true that the risk of mortality and the risk of hospitalization and intubation all go up with age, particularly after 50, particularly after 60, and particularly those people who are both elderly and in confined environments like nursing homes. And so that's the first. The second question about age was, does age affect your likelihood of having a relapse? This isn't a COVID-19 question, but an age-related question that I thought might be nice to just remind ourselves about. Dr. Hirsch and I have had this discussion on many occasions. I think we see it much the same way as our general practicing community. MS is always inflammatory from before you're ever diagnosed throughout the course of your MS. MS is also always degenerative from before you ever have your diagnosis through the course of MS. It varies in individuals, but the question is the likelihood of an attack, and that is the likelihood of the inflammatory component, the same at every age? And the question is, the inflammatory component of MS progressively diminishes in most people as they age. The power of immunity and the power of autoimmunity diminish as one ages. And so the likelihood of relapse does go down decade by decade by decade in populations. Every individual's a special case. And so I certainly have had people in their 60s and 70s with a relapse and people who are quieter in their youth. But by and large, the newly diagnosed patient, the newly diagnosed person with MS, the younger person with MS is the most likely to have relapses and inflammation, and we treat accordingly. As one ages, the likelihood of an attack, the degree of inflammation generally goes down, and our medications should be considered accordingly. So that's an answer to a question that I wanted to dive into. Peter, if you'll take over, and I think since I gave a long-winded answer, I think I'll let you get up.
Actually, while Dr. Hendon was talking, and I'm sure Peter will appreciate this, I found 3 questions that are all related to the COVID vaccine that I think that I can go ahead and tackle one right after the other. So I will give Peter a little bit of a break, and I'll just jump into them. So one question that I see, can you still get COVID after getting the shot? And can you shed COVID after getting the shot? This is a very good question. So the way that these vaccines work, at least the ones that are already authorized on an emergency use basis, those are the Pfizer vaccine and the Moderna vaccines. The way that the vaccines work is that there is a little piece of genetic material called mRNA that is encapsulated in a lipid vector, and that gets injected into the arm as part of the vaccine. Once that piece of genetic material is injected, it gets taken up by the host cells, which are your white blood cells or lymphocytes. And within that host cell, the host cell is then able to read that little piece of genetic material and create the spike protein that actually gives the coronavirus or the COVID-19, the SARS-CoV-2 virus, its virulence. Those are the little spikes that you can see on the molecular picture of the virus. Once those spike proteins are created, they then are able to leave the host. And what happens then is that a new white blood cell can grab onto it, and another white blood cell can then latch onto it, learn what that looks like, And that is how the antibody response is created. That is how the immunization process starts, where there is recognition of this new protein, and then multiple antibodies are created that are then able to recognize what that looks like. So if a person is infected with that coronavirus, the host, the person, is able to mount a quicker immune response to lower the risk of actual virulence or infection. Now that takes time, meaning that immediately after you get your injection and you start getting some of those reactions, that means that your immune system is getting to work. That doesn't mean you're sick. That means that your immune system is starting to activate so it can provide that immune response, but it does take time. So the simple answer to that question is yes, you can actually still get sick right after you get immunized. It does take a few weeks for that immune response to work. And then with these two mRNA vaccines that exist, you need a booster shot at least 3 to 4 weeks later. Now, if there is some delay because there is a delay in the vaccine rollout, that's okay. If it's a few weeks later, that's okay. Still go ahead and get your booster shot. But yes, you can still get the coronavirus and you can still shed COVID immediately after getting the shot. Now, how long that immunity lasts for, we still don't know. And that's the evolving process here where we're still learning about how long this immunity will last for. But we do anticipate that there will at least be an annual booster shot that will likely be required, especially when there are more mutations and variants that come to play, just like with the seasonal flu vaccine. And so that's the answer to that question in terms of whether or not someone can still get infected. And we still don't know with someone who does get vaccinated whether or not they're still going to be able to pass on if they actually do get exposed to the COVID-19, whether or not they can still pass it on to someone else. And we still don't have a clear answer to that, which is why we recommend that everyone in the household eventually does get vaccinated and to continue wearing masks and abiding by the CDC precautions to lower the exposure rates.
And Dr. Hersh, I think following along with that question, there is one question from Karen, that is, what if you can't get the second vaccine? As many of you know, the testing has really been, at least for our current 2 approved medications, the testing in terms of how effective they are, which is roughly in the 95% level of effectiveness. That's based on getting both of 2 vaccines. But we do know that there is significant immunization at a lesser level than 95%, even with a first vaccine. So the first vaccine, as Dr. Hersh told you, not in the first few days, but by 10 to 14 days later, creates a significant level of immunization, which is boosted by the second. But there is still some degree of, a significant degree of immunization even with the single one. So some countries, such as England, are wondering whether or not the strategy is to vaccinate more people with fewer shots. The American experience is to go by the science, and that is to try to get a second vaccine in for everybody that we can. Peter, Dr. Hersh and I have been so excited about answering the questions that we've left you out of our circle. So what are the questions that you want us to consider?
Sure, not a problem. Similar where you are combining different questions, I'll do the same because there was a question, is MS considered an underlying condition? And another question was, and another question was,
not to say that yes, it is considered an underlying condition, but yes, I did see that question, and I did want to make sure that we answered that.
Great. And kind of part B to that is, are MS patients considered a high-risk population in terms of registering for the state's vaccine phasing plan?
If you would like, I'll go ahead and I'll tackle that question. So,
sure, please.
Yes, we get that question quite a bit, because we certainly understand that a lot of our folks who are coming in to see us are actually quite excited and anxious to get their vaccine. Each state is doing things differently in terms of rollout and where they are in their rollout. Some states are still just vaccinating healthcare workers and those who are living in assisted facilities, and other states have already been able to move on to other populations of folks who are considered first-line workers, those who are over a certain age and have certain comorbidities. As of today, multiple sclerosis has not been listed as a significant comorbidity that elevates the risk of COVID-19 susceptibility. And this is what we have been discussing for some time now. There are other comorbidities that folks with MS can have, which Dr. Hendon outlined earlier, and of course, age as well. So having MS alone is not considered an elevated risk factor, and therefore an individual may not be able to get the first vaccine until the general population. Now, of course, that is pending the CDC guidelines and what they are listing as comorbidities, and whether or not they are listing being on an immunosuppressive therapy as a reason to be bumped up in line for a COVID-19 vaccine. So what I would recommend to everybody who is listening in, to make sure that they are going onto their local and state health district website to check in to see where they are in terms of vaccine rollout, what tier they are in, and what guidelines they have in place in terms of folks who are living with certain conditions and on certain immunosuppressive therapies.
And Dr. Hirsch, I agree entirely. So it's a good news, bad news statement, a yin and a yang. The good news is that MS in and of itself does not increase risk for COVID-19. And we've been saying that consistently through the past year. So that's the good news. The bad news is that may mean that people with MS have to wait a bit longer to get their immunization, whereas I would prefer anybody be able to be moved earlier in line. It's been my experience that people with MS in my practice have been almost to a person more fastidious about mask wearing, hand washing, social distancing, working from home when possible, etc. Although we say that MS does not increase risk in and of itself, MS with high level of disability creates the risk because of the disability. MS, as you age, creates risk because you're aging, and that is to say, the risk goes up with age. It does appear that the greatest risks aren't the MS, aren't the immunosuppression, but the comorbidities and age, which is why we pay so much attention to general health and trying to maintain wellness and exercise, healthy diet, healthy weight, stopping smoking, etc.
Great, thank you. Another question, does COVID-19 change the course or progression of MS?
And I can answer that simply. There is no evidence that COVID-19 changes the course of MS. Now, the thing that many of you have been aware of is what's called the long haul syndrome, and that is there are people who have MS, sometimes mild MS, sometimes more severe MS, who really do have a particularly prolonged recovery. And some of the symptoms they're having mirror the symptoms of MS. And so if you said, what is the long haul syndrome, and that is the enduring months of symptomatology after you've recovered from COVID-19, it's often brain fog or cognitive symptoms. It's often fatigue. It's sometimes a sense of just malaise, not feeling well. If you're already not feeling well because of MS, it can compound those symptoms. But simply stated, COVID-19 does not appear to either cause MS, cause MS attacks, or change the progression of MS in individuals.
Okay, great. I'll ask one more question, and then I'll defer to Dr. Hendon and Dr. Hersh, who are monitoring the chat box to see if any one particular question jumps out at them that they would like to pose as we're coming up against the hour. In terms of, has there been any information on pediatric MS and COVID-19?
Dr. Hersh, would you like to jump in? And I'll be happy to join you if not.
Sure. No, that's a great question. So just like the general data in the general population on the pediatric population with COVID-19 and with COVID vaccination certainly are limited, including in the MS population as well. Right now, we don't have any data to report on effectiveness of vaccinations in the pediatric population as of yet. But we certainly are attempting to gather information on the pediatric MS population in all kinds of different registries. So off the top of my head, I don't have any special pediatric data to report. I know that we are trying to collect data through not only registries in the United States, but also in Europe as well. But I'm not aware of any special pediatric MS data to date.
Great, thank you. So either Dr. Hendon or Dr. Hersh, did you see any remaining questions in the chat box that you wanted to pose? Rather than answering a question, maybe a comment that I would like to make, an overview. First is how delighted I am to see such a wide participation for this MSAA webinar. It's something, this subject is one that has caught the attention of the nation and people who don't have MS and people who do have MS. I'm also delighted that we are learning more, and delighted that for the first time we have a vaccine available. We didn't when we began talking. What I began saying when we had our first webinar, and I would say again, we're still learning. This is a problem which has evolved over the course of 1 year. We mostly have gotten it right. Mostly the things we were saying a year ago are true today, but we're still learning and developing better strategies for dealing with this unexpected pandemic. But I can't tell you how delighted I am to be paired up with Dr. Hersh and with you, Peter, to be able to talk about this in a forum, what we know today, while we still puzzle about the future, and delighted that we'll be doing this again in a few months. Great, thank you. Dr. Hersh?
No, I echo Dr. Hendon's sentiments, and I continue to thank the MSAA for the opportunities to get this important, timely information out to the public. There's still a lot of unanswered questions, and I know that there can be frustrations, regarding the fact that we still don't have certain answers to give. But I do want to preface that by saying that there are many an effort to answer some of these questions in terms of the effectiveness of the COVID-19 vaccines in certain populations of folks on disease-modifying therapies and classes of disease-modifying therapies. How long does that immunity last for? How good is that immunity right off the bat? How many times are they going to need a vaccine in the future? How many boosters are they going to need this year with new variants and mutations coming into play? And what are more stats when it comes to the MS population, COVID-19, and vaccines? And I do want to provide an uplifting message to everyone on the line that efforts are in place. There are many large databases that are currently being compiled, so that way we can answer these questions. And hopefully when we meet together again in April, just like today when Dr. Hendon and I were able to provide information on 2 vaccines, hopefully when we come back together, not only will we be able to provide more information on the existing vaccines, but also new vaccines and maybe some new data as it pertains to the MS community. So I will say stay tuned.
That's a great message, and thank you both so much. I really appreciate it. Well, that does conclude tonight's webinar, which will be archived to our website within a few days. So I would once again like to thank Dr. Barry Hendon and Dr. Carrie Hirsch for keeping us updated on this very important issue, and thank our funding partners, Bristol Myers Squibb, EMD Serono, Genentech, Novartis, and Sanofi Genzyme for supporting this webinar series. Also, we ask you to take a brief survey that is coming up next. Your feedback is important to us and will help us secure funding for future programs. So on behalf of MSAA, Dr. Hendon and Dr. Hersh, thank you so much for watching, and please stay safe.